Great. Hi, everyone. My name is Michael Stewart. I am the Director of Education here at the OI Foundation, and I want to welcome everyone to today's the third and final large group meeting of our PCOR Award, the Leveraging Virtual Communication to Advance PCOR adoption by the rare bone disease community. During today's meeting, so we're going to run a few hours long, and we have a lot of really fantastic speakers and topics to cover, in addition to a presentation I'll be giving near the very end of today, which you'll want to look forward to that. Before we get going with today's meeting, I just want to remind everyone that today's session is being recorded. So this meeting, like all the other large group meetings, you can find on the OIF's YouTube page, and also the PCOR Institute itself publishes our meetings on their website, which you can find more information there. Also, I wanted to remind people that we're going to have various presentations throughout this afternoon, and that if you have any questions, I think we're going to be on the smaller side today. However, we ask that if you have any questions, please save those for the designated Q&A periods that we're going to get to later, just so that we can best hear the speaker information. With that being said, I want to just briefly show the different organizations that the Rare Bone Disease Alliance is representing. So as you can see here, we are a broad coalition of different patient advocacy groups. We represent a broad range of disorders and diseases, and we are so happy to represent them here today. And with that being said, I want to introduce Tracy Hart, who is the CEO of the OI Foundation, also my boss, and she's going to go over more about what we'll be talking about today. Tracy, hello.
Hello, thanks, Michael. And a big welcome to everybody that's on the call today. Thank you so much for joining us. As Michael said, this is the last meeting in this PCOR Award. And if you take a look at the agenda, we have a really, I think, really fabulous agenda today, because patient-centered outcomes research isn't just about one thing. It's about connecting people and collaborating with your community and other communities. And we're going to hear about that today from two specific organizations. One is the FDA MAS Alliance, and then the other is Tin Soldiers. So we're going to talk more, and I'll introduce them in a minute. But first of all, I think most of you know, many of you know anyway, that Dr. Laura Tosi is the principal investigator of this award. She is at Children's National here in DC. She's on the OF Board of Directors, our Medical Advisory Council, and she's also the chair of the Rare Bone Disease Alliance Steering Committee. She is traveling right now. You can probably see her name, but we're a little bit concerned about her internet connection. But we wanted to quickly, just for, I think it's not even quite 10 minutes, talk about what we have learned through this project and why PCOR. So at our scientific meeting, I guess 2 weeks ago now, I had the opportunity to do a little recorded message with Dr. Tosi. And I apologize because I am the interviewer again, so you're going to see me again. But I wanted to share that, that short video with you, which kind of sets the stage for today. So, Melissa, I will ask you to share that video.
Hi, everybody. I'm Tracy Hart. I'm the CEO of the Osteogenesis Imperfecta Foundation.
We don't see the video.
I'm sorry. I'm the director of the Bone Health Program at Children's National Hospital in Washington, D.C. So,
sorry about that. Michael, can you spotlight me, please?
Hi, everybody. I'm Tracy Hart. I'm the CEO of the Osteogenesis Imperfecta Foundation. And I'm Laura Tosi. I'm the director of the Bone Health Program at Children's National Hospital in Washington, D.C. So we are here to talk to you today as we start this meeting about this award. And Dr. Tracy, I'm going to ask you a few questions about the award, and we can move forward from there. That works for you? Absolutely. Great. So let's sort of set the stage for everyone. What was the reason behind the award? Why was it so important to bring all the Rare Bone Disease Alliance groups together? And why is it so important to patient-centered outcomes research?
Well,
we have just completed a award for the OI Foundation. And we were very excited about all the new tricks and tips we learned for helping patients get their voice to the table when research is being done. And since the OI Foundation supports and organizes the Rare Bone Disease Alliance, it was a natural next step to say, let's share this. Let's see what we can do to help the Alliance deliver even better support for the rare bone disease community.
So I think we all know that the Rare Bone Disease Alliance is made up of 14 different organizations, and we're all at different stages of our development and who we are as organizations. Was that something that was important to you as we started this award, that we looked at, you know, what are our commonalities versus what makes us different? Or
Well, as a clinician, I'm an orthopedic surgeon by day and by night. I recognize that virtually nowhere does someone only take care of one rare bone disease. So we have a lot of shared experiences as clinicians, and the patients have a lot of shared experiences. And the question was, how can we build on it so that we do more to improve access to care and quality of care for everyone with a rare bone disease?
excellent. So this was called the convening. I think this is terrific because we convened. We met together. We did many meetings throughout this award. But what are some of the lessons learned from all of us meeting together?
Well, first of all, this award was originally designed for someone to have one good old-fashioned one-day event. And if COVID's taught us nothing else, it's taught us that we can be far more inclusive if, in fact, we at least are hybrid or completely on Zoom. And so that our convening award was, as Tracy said, many different meetings, both as we met quite regularly with the leadership of the Rare Bone Disease Alliance partners, and as patients who are part of that full care picture gave us their insights on patient-centered outcomes research. And welcome to meeting number 3. We have not one, but 3 different meetings so that we could have more shared experience, again, across a spectrum of individuals. So that this has been a quite crazy experience.
That's
We've
right.
done so much, but it's also been great fun, and we've learned so much. And I think the really exciting thing was how many ways there are to skin a cat. OI may be the most common of the rare bone diseases, but we learned so much from our alliance partners in terms of how to bring people on board, how to share, how to get more clinicians involved in caring for patients. It was a great shared experience.
So I'm going to get a little personal with you now, because I think people would like to know, how has patient-centered outcomes research affected you personally as a physician? Has it changed how you care for patients, or how you look at care?
It changed care, per se. It changed for me how we're asking questions. That, you know, in medical school, whatever, in practice, you have ideas about what you see are the key problems that need to be solved. And I assure you, I haven't given up on those. But it turns up your hearing aid. You know, it makes you listen harder to what patients are saying is bothering them, what they need to know. And I think that is the great thing that PCOR and PCORI, the organization that funded us, really have brought to the table in healthcare. Just because you have perfect blood tests doesn't mean you're doing just fine. And we have to be sure that the whole person feels that they have a good quality of life.
I think that's so important. I think it's something that, you know, I've learned too through this whole process is how important the patient voice is in everything you do. You know, it should be in every part of research, every part of programming, every part of developing, as we're going to hear later today, a new identity for your organization. I mean, it needs to be everywhere.
And getting back to the question you just asked, I think it makes you a better clinician because you are, as I said, turning up your hearing aids to listen a little bit harder to what the patient has to say, and to value it more. I'm embarrassed to say that, but it's a really important step forward.
So what now? Where do we go from here? We had this wonderful year of convening and meeting together, and now what's next? What's next for us?
Well, for us, both as the OI Foundation, but also for the care of patients with rare bone disease, I think that we all know that there is a terrible dearth of care available for our adults, both as kids transition into adulthood and for our growing number of seniors. And how do we improve that? And this is where I'm hopeful that over the long term, the Alliance will work together. Because as I mentioned earlier, although the diagnoses are different, the science is different, the presentation is different, there are a lot of shared parts to rare bone disease. How can we work together to ensure access? How can we ensure that patients are getting the highest possible quality? How do we make sure that the institutions where patients might be hospitalized are prepared to give the right kind of care at the right time? This is a big unknown. It's going to be a lot of hard work, but it must be a priority.
It's just the beginning for
Right.
all of us, right?
Right.
So I know we're looking forward to a great meeting.
Yes.
I guess here we go. Thank you, Dr. Tracy.
Thank you.
Great. Thank you, Dr. Tosi. I know you're on the line somewhere out there, but thank you for those words and for setting the stage for today. So I have the great privilege of introducing our first speaker today. Adrienne McBride is the executive director. Did I get your title right, Adrienne? Is it executive director of the FDMAS Alliance?
That is correct.
Great. And a good friend and colleague, and she's going to talk to us about a really wonderful initiative, project, journey that they went on in changing their name, changing their website, changing a lot of the outwardly facing materials that we see, but keeping the mission the same. So Adrienne, I'm going to turn it over to you.
Thank you. I'll share my screen and can everybody see that?
Not quite yet. It says you've started screen sharing, but I don't, there we go. Now we see it. Perfect.
Excellent. Well, first I want to thank Tracy for having me here today, and I'm really excited to do my presentation, renaming and relaunching the Fibrous Dysplasia Foundation. It is a privilege and an honor to be the executive director of such a wonderful organization. So my agenda today will basically be to discuss fibrous dysplasia, McCune-Albright, give a little overview of that, chat a little bit about the organizational life cycle of a not-for-profit, discuss our original mission statement and the renaming, and I'll briefly go over outcomes and our next steps, and I will handle any questions from there. So to begin, fibrous dysplasia is a genetic disorder, and it's caused by a random mutation of the gene GNAS1, and this gene mutation takes place after conception. Fibrous dysplasia, which is the skeletal part of the disease, is a condition when bone is not replaced properly, not overturned properly, and soft stringy tissue, which is more fragile than bone, occurs. Bones are prone to breakage, and there can be uneven growth, bone deformities, and limping many times. McCune-Albright syndrome includes at least two of the following of the three features: fibrous dysplasia. There's also skin indications. There are brown patches of skins. There are spots with irregular borders, and they may be present at birth. And then there's endocrine disease. Some of that might be excess hormone conditions. As you can see by the graph I have here, many people have fibrous dysplasia, but within that subgroup, there's the McCune-Albright syndrome people reside. And in rare cases, it is believed that some people can have McCune-Albright syndrome without fibrous dysplasia. So a little bit about Fibrous Dysplasia Foundation, our history. We're a 501c3 virtual not-for-profit. We were founded in 2004 by patients and caregivers. We're incorporated in Florida. Our mailing address is in Michigan. Our staff resides in Maryland and New Hampshire, and our board members are global. We have board members in the US, England, and Canada. And there's a picture on the right, and that's Charlie Hart, and he was the visionary and founder behind the organization. So now I'm turning to the not-for-profit organizational life cycle. So this is similar to the product life cycle. So you can see in the startup phase, the organization's founders are developing the idea, they're getting support, they're getting the tax exempt status, and it's really exciting. And basically the organization at this point is run by volunteers and has no paid staff. As you move up the curve, you go to the adolescent stage. Here's where an organization starts building infrastructure. They're formalizing processes. First, paid employees come on board. Outsiders, meaning those who are not friends and family, join the board. And there's an implementation of administrative systems, and there are a few in place already. When you get to the mature part, that's when the organization's program and fundraising are functioning at a high level. The original founders have rotated off the board of directors, and the board becomes more diverse. Administrative systems are well developed, and the focus of the not-for-profit is on the quality, scale, and impact of activities. The organization is collaborative and provides leadership in the community and the not-for-profit sector. And then, like all good things, it starts to drift. The organization starts to face crisis. There's mission creep. There's a whole bunch of things that can happen at this stage. So in 2019, when I came on, our first paid executive director stepped down in March 2019 for bigger and better things. We had our patient conference postponed. Our visionary and founder, Charlie Hart, passed away in November of that year. Our infrastructure, our operating infrastructure was aging, particularly the website. There was no formal fundraising plan, and our 10-year strategic plan had ended. So we were here, if you can look at over here on the star, we were heading for stagnation. And this isn't unusual. This is normally what happens in an organization. So what did we do? We had a planning meeting in New York City in February 2020. We reviewed our 10-year strategic plan and assessed what worked and what didn't work. We discussed our mission statement, the name and branding, and then we prioritized fundraising and making sure that our website was up to par. So this was really a pivotal meeting. And February 2020 was right before COVID happened. We all know what happened then. So looking at our mission statement, which is our before mission statement, and I'm not going to read this to you because even the most committed board member cannot rattle this off. The mission was generally on target, and parts could be removed or revised or de-emphasized, but some aspects of the mission simply weren't being met. We were not really focused on cherubism and other related diseases. We were really focusing on fibrous dysplasia and McCune-Albright syndrome. So afterwards, we revisited the mission statement, and we have a more concise mission statement now, which is the development of evidence-based treatments and foster the well-being of individuals with FDMAS by advancing cutting-edge research, channeling the voices of individuals with FDMAS, and sharing the information with the medical community. This is still a work in progress. We need to make it more simple and more easily accessible, but we're on the right path. So one of the big considerations that had been boiling up was our name. Fibrous Dysplasia Foundation is a trusted name to those who are familiar with the high quality of our work, but we felt that a name change could be more welcoming and inclusive. We felt that a much larger constituency who needed the resources that we provide were missing out. And some individuals believe that we only serve those with the bone lesion aspect of the disease, when in fact we serve all patients, no matter how severe their disease burden. And then one of the other things that we kept on coming up against was the word foundation. To many people, foundation insinuates that the primary function is to give out grants, when in fact we were relying on charitable gifts in order to support our programs of research, education, and advocacy. So for the name change process, we had many name suggestions. Everybody had their own ideas. So we sent out a survey to the community because it was very, very important that we get the input of the patients. We had a vote within the board, and then we had a vote with constant contact to the community to make sure that we were doing what the community wants us to do. I had a discussion with our medical advisory chair to make sure that we were representing the name of the disease state correctly, and we considered the legal ramifications. Our decision was we were going to keep the overall branding and change the name by registering as doing business as a DBA. So how did we announce this? We sent a postcard to our entire database. Our end of year campaign was launched, focusing on our new website and our new name. We sent out emails. We had a big social media campaign, and we sent out a mailing. And we unveiled our new and improved website to much acclaim. Everybody was really happy. So if you look at the life cycle of a not-for-profit, we're moving forward. We're coming back to the startup and going up the cycle again, so we can really focus on our mission. I put this here, Hofstadter's law, because my colleagues and I talk about this often. There's a law, it's called Murphy's Law. We all know about that. But it always takes longer than you think it will take, even when you take into account Hofstadter's law. Those in the real rare disease community set many goals, especially those who are searching for treatments and cures for rare diseases. And sometimes you spread yourself so thin that you need to be as focused as possible and really set priorities. So this is always something that we keep in the back of our mind when we're planning. It's going to take longer than we think it's going to take. So we had some unanticipated challenges, but they all led to opportunity. For many people in the not-for-profit space, many organizations, I'm not telling anything here that nobody doesn't know, that there are always too many cooks, too much passion, and not enough money. So when we looked at redoing our website, we had to be frugal and we had to know what we wanted. And there was a lot of discussion and a lot of passion about how we were going to launch the website. We also found out that our bank refused to cash the checks with our new DBAS. And while this was a easily solved problem, it took way longer to resolve, with many trips to the bank than originally anticipated. Along with our state registrations, now we have to have a trade name filings, which, it's just par for the course. But this whole process has now triggered a formal review of our bylaws, of our articles of incorporation, and our governance. And this has been really, really good because we now have a sense of optimism. There's a stronger focus. We have a revitalized or a vital new governance committee. And this month we had a board retreat, and our board of directors are really invigorated and really excited about how we move forward with our mission. So I'm going to end here because there's a lot of questions, I imagine. This is an overview. And I just want to thank everybody for giving me this opportunity. And I would encourage you to please go look at our website, fdmasalliance.org. We love to get feedback. And we're just so grateful to be part of the rare bone disease community. Thank you.
Thanks, Adrienne. That was great. Thank you. I know people have questions. I have one right off the top, though. If we could start is, did you have a committee of people that were working on this, or was this was it led by you and your board chair, or were there constituents involved in the process? Like, or how were they? I know they were involved. How were they involved?
So there was a few people on the board who were very passionate about getting the board, the website going. The website was the main focus because our website was in 2016 was very outdated. And during this process, we were also looking at our other systems, our database, and moving things forward so we could have, over time, people tend to jerry rig things. They make workarounds, and the workarounds become part of the process. So there was a lot of that going on, but we had a couple of really passionate people on our board. And at the time, our SAC chair was very involved in helping create the website. But there was tension, but I think the tension was good because we listened to everybody. Now the website is still a work in progress. We're still building on it. It's a very foundational website because we had so much content in our former website. So we're looking to be more simple. We're working with a firm right now to work on our SEO to make sure that our content is very readable and accessible. So to answer your question in a drawn out way, there was a committee and people chimed in at every possible meeting. It was no secret what was going on. But there was also a lot of tension at this time in the outer world because this is during COVID and people were very afraid. Overall, they were afraid for their jobs. Meeting setups were difficult. There was a lot of ambiguity in the air, and we forget that now that it's all over. Well, not all over, but now that it's calmer.
Yeah, that's a really good point. Liz Malloy had a question. Hi, Adrienne, how many board members do you have?
Right now, we have the capability of having 15. We have 14. Because we have the new governance committee, we're having several people who are really burnt out. They're going to roll off and take another position in the organization. And we're looking to diversify and grow our board.
And remind people your staffing structure. What do you look like?
So our staff is very small. I'm the only full-time employee, and I have 2 part-time employees, and that's it. So it's a very, very lean staff. So there's a lot going on, a lot of plates that are being spun. So having priorities is number one. Like we have to know what we're focusing on.
Other questions from people? I don't want to hog you, Adrienne, but it's funny when you talk about having a small staff, managing consultants is a huge time commitment. If you hire someone to do your website, you hire some whatever. I mean, how did you manage all that?
It was very time consuming. We really only hired, at this time, I forgot to add, our main colleague that my director of community engagement was taking her maternity leave. So there was just basically 2 people. And we relied heavily on our board participation. But it was challenging at some moments. We had also hired at that time a firm that reviewed our whole fundraising, did a fundraising assessment, and we had a fundraising plan. So we were basically repairing the airplane while it was in flight, trying to keep everything together. And it was a difficult process, but it's a normal process at the stage the organization was. It was just harder for us in some ways, but it was easier for us in some ways because we were small. We are small.
Right. Dr. Scott, I see your hand raised.
Thanks. Thanks. That was really interesting talk and very insightful. And I could see that life cycle. I've seen that play out over the years in a few organizations that I've been part of. Fortunately, none in the FOP space. But I wanted to ask you, now that it sounds like you're really consolidated and regrowing and back at the bottom of that growth cycle, how do you envisage the future in terms of more international? I know you mentioned the UK, Canada, and the US, but how do you envisage broadening the global influence of the organization?
Absolutely. My predecessor, Deanna Portero, I think a lot of people might know her. She was instrumental in making sure that, along with Mike Collins and a number of other people who preceded me, to convene a international consortium. And over the last 2 years, we've been working on formalizing that. So there's an international consortium for FDMAS as well. So we work very closely with those group of researchers. And in 2023, we're discussing having a patient conference in connection with an international researcher conference, which will also celebrate or acknowledge 25 years of studying FDMAS at the NIH. So we're looking forward to 2023 with a lot of excitement.
Sounds great. Thank you.
Adrienne, we have a question from Ted Trahan. Is it correct that the revamp was a 2-year process from February 2020 to April 2022?
It's ongoing. It's not going to stop. But we reached our milestone. Basically, from February till November, that's how long we went into full fundraising and website mode. That's what we really concentrated on for that short period. And so we were ready and teed up by the time we got to our end of year campaign, and we were able to really show a reemergence of the organization. And it was also, I think, a very positive experience because, again, the world was very much in flux at this time. And we really had to make a decision whether we were going to grow the organization and make the organization stronger or not. And our patient community, our board, they're very passionate. And we have a lot of challenges because everybody is dispersed like so many other rare diseases. And so we really have to focus on, virtual location and real community. Yeah.
No, that's great. We're all pivoting and we're getting dizzy from pivoting. I know. So from Dr. Tosi, what are your top priorities for educating clinicians as the FDMAS?
So educating clinicians is something that we really do need to focus on. It was one of the main reasons why the organization was founded. I spoke in depth to Andrea Harles, who is Charlie's wife. That has not been our focus thus far. I'm sure it will come up. Right now, we're convening and formalizing our patient advisory council. We think that this is really, really important for patients to have a say in what we're doing and not necessarily be on the board. We've been doing webinars that have been patient focused. We did 6 of them last year. They were funded partially by Ionis and Ultragenics and our individual donors, and they were very successful. We have our we have our physician database. We had that in our previous website, but we've made it more user-friendly. And I understand a lot of doctors are going to it to look up names of physicians. We also connected that to the NORD. I think there's 33 centers of excellence. So again, we're working really hard to make our website consumer-friendly, and also we want the community, the FDMAS community, to be proud of the website and to be proud of what we put on it. And we want it to be the most most up-to-date and expert advice. And we know that there's a lot of bad advice on the internet, whether it's just old advice or it's just outright wrong. We want to be the authority as far as patient advocacy organizations go in this disease state.
I love that. You want people to be proud of their organization. I think that's wonderful. I think people can unmute now. So that's why I was asking the questions. I apologize. Liz, did you want to unmute yourself and ask your question to Adrienne?
I suppose we struggle to get people involved in our organization, even general helping. If you're trying to put out a survey or there's studies going on, getting them to participate, it's so hard to get them involved at that level, considering even getting isn't
so
for us. There's very few of us on the board who are trying to do everything. We're in the stage where there's no pay.
It is really difficult. I'm not going to lie about that.
Sorry, that's it.
But one of the things that we're trying to do is we're working to empower our board with more board training, to set them up as ambassadors, to make them proud of the organization and to be excited and optimistic about what we're doing. We all want treatments and cures, and that's really our North Star. And we know that if we don't come together as a community, if we don't have the numbers, if we don't have the voice, it's never going to happen. And I think by taking and this has been hard for me in the last year because of everything that's gone on, is to be more positive and to be very proud of what I'm doing as the executive director. I'm very proud and blessed that I have this job. And I think it's also transferring to people who are not necessarily affected with the disease. I don't have FDMAS and nobody in my family does. But yet many people in my family are supporting what I do because I am really excited about what we can do to make the world a better place when the whole world seems to be crazy at this time.
So I think we have one more question here from Dr. Tosi. Dr. Tracy, I'll ask it since I don't know if you can unmute, but naming a center as a center of excellence is always tough. What criteria are you using? We have that issue at the OI Foundation.
So we did not name the Center of Excellence. We shared the NORD Center of Excellence, and we posted that on our website to link directly with them because, one, it is not us naming those centers of excellence. This is the criteria that was set up by NORD, and we want to be very clear about that. What we're doing and how we're collaborating.
Was your board on board with that? As far as okay.
No, that was with our medical advisory council. I would not. We vet just about everything that goes on the website through our scientific advisory council and our medical advisory council because we want to keep the standard really high. There's been errors made in the past, not intentional, but we're working hard to make sure that our advice is bulletproof, and it is advice. It's we don't give out medical advice. This is the patient advocacy voice.
Kathleen, I see you have a question. Do you want to unmute and ask Adrienne? It's Kathleen Harper from Osteogenesis.
Hi, Kathleen.
Hi, thank you so much. It's so interesting and helpful. I wanted to know more, if you'd give us more details about the patient. You said you had 6 patient conferences, seminars?
They're webinars. So one of the
things, yeah.
So what happened was our patient conference had been canceled in 2019, and we were set to do a virtual patient conference. And at that time, people just had Zoom fatigue. It was not good, and we didn't feel that we can get the turnout that we needed. So we went to our medical advisory council and we asked each advisor if they would do a presentation for the organization. So we pair them up with different patients. And this, I have to give a shout out for Tova Bernstein, who's our community engagement director. She worked together to have a meeting where a patient would tell his or her story, and the advisor would give a presentation. We had Mike Collins give FDMAS 101 because a lot of patients don't understand fully what the disease state is. We paired him up with a patient. The patient discussed her journey, and then we opened up to Q&A. We did another one for pain. We also did one for craniofacial and dentistry. And we also got some interesting feedback. Like one patient said to me, if I had seen this video, it would have saved me 5 years of doctor visits. So I thought that was particularly rewarding. So, I mean, they seem to be small when we're doing it, but then when we realize the impact of what we're having, it's just really rewarding. And you do feel like, okay, we can do more and we can do better. It's energizing.
Wonderful. Thank you.
Great. Any more questions for Adrienne? Adrienne, maybe you could put your email address in the chat too, so if people wanted to connect with you.
Absolutely. I will be out of town for the next 2 weeks, not answering my email, but I will follow up with anybody who reaches out. And thank you for letting me have this moment to present. And I just want to let everybody know how pleased and excited I am to be part, and the FDMAS Alliance is to be part of the rare bone disease community.
Thank you so much, Adrienne. That was fantastic. Really great. Thanks. Melissa, is the agenda, should we just keep going?
Sure.
Remind me what the agenda says.
I'll share it again.
I think we go right to Amanda, but I want to be sure. Yeah, okay.
Yep.
Great. Okay, we're running a little bit early, so I just wanted to make sure that I didn't miss something. So our next presenter, a group of presenters, and I'm going to let Amanda Callie, who's the co-founder of Tin Soldiers, probably sort of introduce people as she goes along, but I've had the really great pleasure of getting to know Amanda over the last month or so and learning more about an organization called Tin Soldiers. And the team is going to tell you about their mission. But if you look at the title, while looking for one, you may find another, the global search for the undiagnosed individuals with FOP. So Amanda, I'm going to turn it over to you and let you do introductions and introduce your videos. Oh, we can't hear you, Amanda.
Thank you. Thank you so much again. We really, Tin Soldiers feels very privileged today to share our story with you. We hope our story inspires you in some way. We hope you find some human truth in our story that resonates with you, or you find yourself curious and wanting to know more about the work that we're doing. Thank you to the Alliance and the PCOR platform for hosting us. And along with myself, the Tin Soldier team members that are presenting today are Odette Schwegler, who is the executive director, Vanda Harris, who is our communications director, Dr. Chris Scott, who is not only on our board, but also our medical director. And I believe our roles will be listed in the chat section, if that gets done. Our story started with two women making a documentary with a purpose. And I'm a philanthropist. I'm a mother with a son with FOP. And Odette is an award-winning filmmaker and an investigative journalist. Fate brought us together some 11 years ago surrounding FOP. And through the making of this documentary in 2019, the reality that there were so many people with FOP missing came to light. And in 2020, we joined forces and began a journey neither of us could have imagined would be as rewarding as it has been so far. So Tin Soldiers, the nonprofit organization, was born. We are based in South Africa, and the organization is not a patient support organization, but rather a patient identification organization. Our mission is to find people on the globe that are not diagnosed, and also find those that perhaps are diagnosed but remain isolated, and get them all on a pathway to care and support. Ending isolation for those suffering, it turns out, is a complex process, kind of like trying to find a needle in a haystack. So many of us in the rare bone disease world know it's a sense of isolation and poor diagnostic tools and a lack of access to doctors that understand our condition. It's a challenge. So we began the process of searching for the missing members of our community, in some cases, in some of the most remote parts of the world. We do this in less than traditional ways. We lead with a patient voice in everything that we do. Why? Well, because the patient voice is unforgettable, it's memorable, and it's inspiring, because it holds the human truths that everyone can relate to, no matter who they are or where they live. We've built a library of content that speaks to people, physicians, healthcare providers, and the general public. And that library consists of media content like films, public service announcements, CME courses, animated videos. It includes print material, which is diagnostic handbook, diagnostic posters and t-shirts, flyers. So how do we go from content to diagnosis? Well, I invite you to come on this journey with us. We'd like to start by sharing with you a short video that Dr. Chris Scott presented at the PRES conference in 2021. And following the short video, members of the Tin Soldiers team will tell you a bit more about the different partnerships we have, our commitment to sustainability, and our outcomes to date. So I think if you can put that video on, that would be great.
Filming Chris's presentation here in Bosnia in Orange Park. Comments, Carl?
Hello, everybody. Dumela. Hello, I'm Chris Scott. I'm a pediatric rheumatologist from Cape Town, South Africa, at the University of Cape Town and the Red Cross War Memorial Children's Hospital. But I'm here today because I'm a member of the Global Task Force for Pediatric Musculoskeletal Health, as well as the Tin Soldiers Patient Finding Organization. The Global Task Force for Pediatric Musculoskeletal Health has the mission of advocating and improving the care for children with rheumatic diseases and musculoskeletal diseases all over the world. We have a network of approximately 450 regional thought leaders who are healthcare workers in pediatric rheumatology and in musculoskeletal health. And through this network, we disseminate information. We identify projects that we feel would improve the care of children all over the world. So one of the biggest challenges we have, though, is really getting people to care about musculoskeletal diseases. There's a lack of insight into what it means to have a musculoskeletal disease, not just amongst the public policymakers, but also amongst many healthcare workers. And we feel it's really time that that changes. This is scary.
Very nice.
We are looking for people with a rare condition called FOP. Fibrodysplasia ossificans progressiva is a condition which is extremely rare, but because of the risk of harm being done to children who don't have a diagnosis, there was a moral imperative to identify these patients. Patients with FOP should never be biopsied, which is something that frequently happens in the early days. If you see a child with funny toes or with lumps on the back, don't send them to a surgeon for a biopsy with FOP, because the prevalence is 1 in a million, and we know of far fewer than 1 in a million people in the world with FOP. And we anticipated that these people would be living in places of the world where healthcare is scarce or is not easily accessed. And so was born this harebrained scheme of trying to find patients with an ultra-rare disease in places such as Africa, and to identify them and put them on a pathway to care. And so we set ourselves this task of doing that. But how do you do this?
I think from the first day she was born, the doctors could notice the toes, but because it's an unknown disease, they couldn't diagnose her right there and there.
So it was created this methodology of telling stories of patients, using those stories to create an awareness and to create publicity around the stories.
Just take us through the process. How does it start?
The new skeleton tries to develop in exactly the same way as the original skeleton.
Activating networks of people who care to be able to actually deliver care to patients. And this methodology actually seems to have worked really well. It's exceeded all our expectations. One by one, leads started coming in and the team started following up on these leads. At the same time as following up on these leads, of course, there was this creation of the pathway of care, or this improvement in the pathway of care through creating a network of doctors with an interest in FOP, so that when we got a patient, we immediately set about finding a route of care and then getting that patient to actually have care for their FOP. We found some amazing examples of patients with no access to care who, through this process, have been able to access some of the most advanced care in the world for this ultra rare disease that really only people involved with this disease passionately care about.
Gaan dit probleme veroorsaak of nie regtig met die FOP nou?
Yeah. Okay. That was Tin Soldiers. It became this movement with a life almost of its own, with all these energized people and networks.
We need to know that all the clinicians are on board with it.
That really translated into benefits for children in parts of the world that you cannot imagine. Some of the highlights for me along this Tin Soldier journey about finding people have been finding families who had abandoned all hope that they'd ever have care, finding multi-generational families with FOP, being called up about a set of twins, where it turns out there's a diagnosis of FOP from a very rural part of South Africa. Children who would otherwise have walked this incredibly sad and destructive journey towards a diagnosis are now almost snapped out of obscurity and placed on a pathway to care that's going to really impact their lives and the lives of the family members who care for them. Another highlight has actually been finding patients who don't have a diagnosis but have other conditions and doing the same for them. So finding patients with juvenile idiopathic arthritis who had been struggling to access appropriate care for years and who contacted Tin Soldiers thinking they might have FOP. Finding children with even more rare conditions. And some of these stories will be told at the symposium. But those are tangible, measurable outcomes that I'm incredibly proud of, actually, to be able to put these children on a pathway to care. I always say, if you can help one person, that's enough for that person, then that's probably enough for all of us. The scale doesn't matter, but then you start thinking about possibilities of the scale. And you start thinking about how many children there are in the world, living in parts of the world, that are not able to access basic medical care for even fairly common musculoskeletal conditions such as juvenile idiopathic arthritis or clubfoot for that matter. These conditions are much more common than FOP, and yet there are literally tens and hundreds of thousands of people in the world who are not able to access pathways of care for these conditions because of a low level of awareness of healthcare workers and trouble accessing the system, and just a low level of popular awareness of what the possibilities could be if a child isn't moving properly. So I'm looking from the front here to see if I can see any asymmetry. So we're looking if the hands are the same, the hips are the same, the legs are the same, and then you're looking specifically at the toes while he's standing as well. Tin Soldiers was started in South Africa, but the methodology is now being adopted all over the world. So it's going to South America, Russia, Pakistan, India, where the biggest populations on earth live, and where one of these, for instance, children with FOP, who, if there's one born every 44 hours, you know, the most people in the world are being born in those areas, and that's where we're going to find those patients with FOP. So you always want to see that there's a normal T here, and if it goes like this, then you know there's a problem. People are so receptive to this kind of methodology because You find the right people in the right area, and they're on the same mission as you, and offering people a tool to be able to fulfill that almost drive that they have is so powerful. This boy's leg, who can tell me what the problem is there? If we could do this for a rare condition such as this on our continent, what is the potential for other conditions, for things that we also know is out there, things that we know are not being diagnosed, things where we know there are limitations to access, where fairly basic levels of education, fairly straightforward, nuggety kind of interventions can really translate into benefits for patients and have them seen for the first time on a scale that we haven't seen in musculoskeletal diseases before. I think the potential of that excites me incredibly, and it should make anyone working in musculoskeletal health very excited, because we all know our biggest challenge is finding the patients. We all lament the days when the patients come in. It's like, I was referred to a child today with dermatomyositis who's been in care for 18 months without a diagnosis, being diagnosed with eczema, for instance. You know, this is what makes pediatric doctors' heart beat, is finding the patients and giving them early access to therapy. This is what we want: early diagnosis, early access to therapy, a pathway that actually works. And this methodology worked so well for tin soldiers. If we could expand this to include other conditions, we could really make a global difference, and we can have measurable impact. This tin soldiers model has shown the potential. It's roll-outable. It's ready for the world, and it is being adopted by the world.
Amanda.
Great. Thanks so much. So I'm Odette. I'm the program lead for Tin Soldiers. We're going to just hand over to Vanda, who'll take us through a little bit of our high-level strategy, and then I'll finish off with outcomes. So I'm just going to try and share my screen for her slide. Give me a second.
So maybe I should start speaking in the meantime, but thanks for that.
Thank you.
I think you've got a pretty good sense from Amanda and Chris of what Tin Soldiers is all about, what we do, how we go about doing it. And you would have heard Chris talking about awareness and how important awareness is in so many instances. And so from a communication point of view, which is what I look at, we've developed a very clear and simple strategy. And that's what I'm going to share with you today. It's really based around these three pillars, and it really is quite straightforward. So the very first thing we do is we look at our audiences. Who is it that we're trying to talk to? And I've given you some examples here. So it may be healthcare professionals and clinicians, it may be auxiliary healthcare workers in certain communities. You will have seen some of those in the underserved areas in South Africa where Chris was on the video just now. It could be policymakers in certain countries, like we're working right now with Brazil, or it could be the public. And once we've identified who those audiences are, then it's really important to make sure that the content we're developing to put in front of those audiences is engaging and relevant. And I think both Chris and Amanda spoke to how important storytelling is, and it's certainly what Tin Soldiers was founded on. It's very important to show patient stories, to show real human engagements and interactions, because that's what deeply resonates with people, and that's what they will remember, that feeling, long after they've forgotten everything else. Language, again, is very important, and we found that's why our work travels so well, is because we can translate it and subtitle it and turn it into relevant language for other territories that the work may travel to. So that's from a content point of view. Obviously, once that content's established, it's very important about where we distribute it. So it could be anything from, if we're targeting clinicians on a CME platform, or it could be at a conference or a congress, or it could be an outreach like you saw in an underserved community. And Amanda mentioned this as well, but I think it's really important. We've developed an extensive library of content. We now have numerous videos, lots of very rich storytelling, patient stories, journeys, as well as all of our point of sale and our very diagnostic, simple to understand elements that we share and we distribute globally. And then last but not least, we rely very heavily on partnerships as well. You know, it's important for us to form partners with people who have similar objectives to us, so that we can extend the reach of our messaging and it works for everybody. We're going to show you a short video straight after this, which gives you a very good example of, we partnered with Toyota, the car company, and out of that we got the use of their vehicles as well as petrol, and it helped us get into underserved, very hard to reach communities. And they got out of it a beautiful piece of content which showed the work that they're helping facilitate in these areas, as well as their vehicle and how it performs on the ground. So we share, they share, double the reach, double the impact. It's our audience extending to their audiences, and that's how we also get outside of the silos. We're not just working consistently in the silo of, in our case, FOP. It really helps us extend our messaging. Thank you, Adrienne.
Great. So I'm just going to stop share so that that video can play.
We are looking for people with a rare condition called FOP. And so was born this harebrained scheme of trying to find patients with an ultra rare disease and to identify them and put them on appropriate care. It's a very strange, very terrible condition to have. It's clear she's got a congenital problem and a genetic problem, but she certainly needs to get to Joburg to see the special doctors there. Do you have a wheelchair or something? That must be very difficult for you, and that must be something we can try and help with.
Okay, so I'll go back to sharing the screen. So I'll just go through very quickly some of our high level outcomes and highlights. So we started really becoming operational in late February of 2020. So you can imagine how much of a pivot we had in March of 2020. So this is just a very high level of what we've managed to achieve in that time. So central to everything we do is healthcare professional HCP education globally. Since 2020, we have educated over 1,100 healthcare practitioners, both professionals as well as primary healthcare workers. And we've done that on multiple platforms. So we created a CME master series that we initially led as a webinar. That initial touch point trained 260 healthcare professionals from most of the continents on the planet, and I think it was 16, 17 countries. And then we've also gone to congresses, and then, as you saw, those very on-the-ground outreaches to clinics in underserved communities, starting in South Africa with those. Just a little bit about our strategy in that we are South African based, so we incubate here. We pilot our programs here so that we can then adapt and roll them out internationally. So far, we have 731 healthcare professionals on our database, and the reason for that database is so that we can more easily connect people to pathways of care. So if we hear about a patient, for example, in Turkey, we can look on that database and understand which of the clinicians in Turkey have connected with us, have been trained, and that we can connect those people to. So that is, it's a global resource for us. The other thing that database helps with is sustainability. So we have a growing number of, we call them clinicians collectives, where these clinicians are people who are dedicated really to raising awareness, but also looking for people with FOP and really flying the flag in their own communities. And those networks are growing in places like Africa, India, South America, as well as South Africa. So before we started, we really had one central lead, for example, in Africa being Chris, and now there are several doctors with FOP understanding and patients on the continent. Okay, so everywhere we go in terms of training healthcare professionals, we take a number of educational resources. So we've mentioned the Global Master Series, 7-part series that it was lectures that we recorded with global experts on FOP. Elements of that series have been translated and repurposed for education in Russia, Brazil, and Argentina. In fact, Argentina is about to roll out in partnership with the Ministry of Health, and I believe 6,000 healthcare professionals are being invited to that series of webinars. In the US, Springer Healthcare is also to integrate elements of the Master Series into an expanded FOP recognition, treatment, and hope program. Diagnostic handbook we've created, working alongside the International Clinicians Council. For FOP, and that's really a leave behind handbook that once we've been to clinics, the doctors and nurses, they have this handbook so that they know how to recognize, diagnose, who to contact, what to do and what not to do. And then you will have seen Chris in the clip that he was playing, he was showing the nurses at the clinics a diagnostic tool, being the PGALS tool. I think many of you might be aware of it. It's a diagnostic tool for musculoskeletal pediatric conditions. So where we go to do FOP training, we also teach around this tool, which helps healthcare professionals recognize musculoskeletal conditions in general in kids. And FOP is being integrated into that tool specifically. The T-shirts, posters, flyers, they were mentioned earlier. This is just some pictures of them. And these are themselves diagnostic resources. You'll see we show the toes and the lumps on the back, which are things to look out for. There are also resources in terms of who to contact, et cetera, et cetera. Awareness, very key to what we do. So Amanda's been through this, but just to give you an idea of some of the content on that library that we've all mentioned. We have public service announcements, which are short television ads, which have been distributed across Africa and through commuter taxi TV, and also repurposed in Brazil. The documentary, which we mentioned, aired on Discovery in Africa, Middle East, and parts of Eurasia, and there is distribution in place for streaming in the US and Europe this year. There's a short film that we created that I'd love to share with this group afterwards, and that has been used extensively at congresses, at the FOP family meeting, at national FOP organization meetings, film festivals, etc. And then we use a lot of that in small pieces for social media as well. So created several shorts, almost too many to mention, which are 2 to 3 minute pieces, which are patient journeys, the piece that you saw, and unfortunately, sorry, the quality is not great on this platform, but I will give you links that you can watch it outside of here if you want. And then the master series, which I mentioned. The other important thing to note is that we fund the creation of this content, and it is made available license-free to national organizations, the IFOPA, medical conferences, as well as medical and nursing schools. Our intention really is to create this content and for it to be amplified as far and as wide as possible. And we do this all because we want to identify patients and connect them to pathways of care. So on the African continent, when we first started this work, we had 18 known connected people with FOP. That is now sitting at 40. This includes the diagnosis of a multi-generational family, the first known multi-generational family on the continent. These are pictures of them. as well as a neonatal diagnosis. So, but in this family, you see exactly the two stories of the kinds of people we look for. So the father was diagnosed when he was 12. His family were given no resources. They were just basically told to make sure he doesn't hurt himself. So he grew up very isolated, believing he was the only person in the country with this condition. And that this is how we found him when we eventually did. And he needed all sorts of care, dental care. He's now connected in with the IFOPA and getting life awards and that sort of stuff. And Dr. Chris diagnosed their son when we met with them. So that child will now be connected into that pathway of care that wasn't afforded his father for most of his life. In India, three new FOP cases. One of them, I believe, a new diagnosis. Chris, correct me if I'm wrong, and the other two new identifications. And then a new pediatric diagnosis in Australia. Sorry, it shouldn't say African Australia, it should just say Australia. And then as we've always said, is that in looking for FOP, because it is musculoskeletal, we're likely to find people with other musculoskeletal conditions. And we took a decision right from the start to say, well, we don't leave anyone behind. So it's not to say, oh, you're not FOP, so, off you go. And so in two ways, we've both extended our training to include PGALs, as we mentioned earlier, but also committed to connecting people with other musculoskeletals to pathways of care. So to date, we've also helped diagnose and connect to care a child with progressive osseous heteroplasia, which is even more rare than FOP. FOP has an incident rate of about 1 in a million, with about 800 to 900 people known globally, where POH, I believe it's about 100 people known globally. A child with multiple osteochondromas who's on a pathway to care, who needed surgery, who'd been in and out of the system for many, many years, and who now has the surgery that she was needing. Child with idiopathic arthritis, who was actually about to be sent in for surgery that would have been unnecessary and harmful, that is now in appropriate care and on a biologic. In Limpopo, we saw, sorry, my numbers are wrong there, 30 pediatric patients and 16 were referred for specialist care. So there are opportunities to scale this model, as Chris suggested, to the broader musculoskeletal category, providing we have stakeholder buy-in, sustainable, and that sustainability and feasibility criteria are met. So in a nutshell, that's what we do, how we do it, and some of our outcomes. So thank you so much for having us.
Wow. That's all I can say is wow. Amanda, did you want to add something to?
Yeah, that is the fast and furious version of Tin Soldiers. Let me just tell you. I think that one of the things maybe, I think I have our first question, which would be maybe Odette talking a little bit more about some of the partners that we've recently connected with that have a system already, a healthcare system where they're working in remote areas, and we've just partnered with them to bring this education forward. And so I think if we could go back to Odette for a minute, but also I really would encourage anyone who's interested in the work, or adding anything to your own condition, your own organization's information to the Tin Soldiers platform, that's something I think that we could start to look for those kind of partnerships. We're established now, and we have some we also have some big partners on the horizon. So we're very, very excited. And when I mentioned earlier that it was kind of looking for a needle in a haystack, the fact that we've found so many needles in such remote haystacks already is really invigorating. And I hope that it inspires other rare disease organizations to really look, because if you talk about research and patient information, this is data that we currently don't have in our databases, and we don't have this information. And truly, I'm not sure if any condition really can get a treatment or a cure without the involvement of a global participation base and data on that global participation base. So I just wanted to add those two things.
Thank you. And Odette, maybe you're going to answer this, but for those of us that represent or whatever that are working in different, with different disorders, you mentioned, Odette, we don't leave anyone behind. So where do you refer them to? Like, how does that happen?
Okay, well, that's an interesting question because it often depends on how we find them. Mm-hmm. So, you know, in cases where we're doing a specific outreach, like, for example, going to the clinics, you know, then there's a referral system that Chris can maybe talk to within the healthcare system. And then obviously, if there's a patient who's been diagnosed with FOP by a doctor, they are connected medically already. But that doctor is then connected in the FOP world to a whole international, global, robust network of experts. And that is true of any one of the 1,000 whatever healthcare professionals that we've educated. If they believe they found someone, they can come to us and through the ICC be connected to the appropriate clinicians. The other, so in more remote places, so in the clinics that we've mentioned going to, in those clinics, they are very remote. There isn't a doctor. They are nurses providing that healthcare. So in many places, not just in South Africa, but across the continent and in places like South America and India, your first defense of care really isn't a doctor. It's often a nurse. So in the clinics that we went to, for example, we then created per clinic a WhatsApp group of those nurses. So if they believe, and already since being there, we were only there earlier now in March, but if they believe that they have seen a child who might fit the FOP diagnosis, they then reach out to us. We take them through, they need to take photos, get permission to share those photos with us. So we have permission to share it with the doctors so they can get a diagnosis, ask a bunch of questions. Often this takes a translator involved because the nurses themselves don't speak English. So we have a translator on the app. And then once we get that information from them, once again, we can go back to our network, and shame we generally start with Chris, who's overloaded, I think, and then figure out what this child has. And if it's not FOP, we still work to figure out what it is. And that is exactly how some of the children that I mentioned in my presentation, that's exactly how some of them ended up being diagnosed. Yeah, in fact, 2 of the 3. And the child with idiopathic arthritis, she ended up being diagnosed because a friend of the family saw the documentary on television and thought it might be FOP and knew that they'd been looking for a diagnosis for this child for 6-7 years. And that's how they connected with us. So yeah, so there are many varied pathways, and we learn as we go, but we make sure that they're connected. And when we say pathways of care, it's not just medical care, it's also patient support. So where appropriate, we also connect people to the national patient support organizations, should they exist, always to the IFOPA if it's an FOP diagnosis. And in the event of diagnoses of different conditions, we are in partnership with Rare Diseases South Africa, who then have a massive network they represent pretty much all the rare diseases in the country. So we can connect people in that way. And, you know, that goes from, we had someone the other day who came up and the child had autism and had the diagnosis, but wasn't connected. So we managed to connect them into the patient organization. So the focus obviously is always FOP, but, you know, we make sure that we look after everyone that comes in our path as best as we can. Amanda mentioned partnerships. So Rare Diseases South Africa, for example, is one of them. We have global partners in the form of the IFOPA and others. But we also look for partners outside of the rare disease space who have networks and operations in place that we don't have to then reinvent the wheel. So our most recently developed partnership is with Mercy Air, and they basically fly doctors and education specialists and others to remote places in Southern Africa. And so we've just done our first outreach with them to Limpopo. And that partnership is something that we see growing. They also work with Mission Aviation Fellowship, which is an international global organization that works to fly people to difficult to get to places. But then also, just importantly, we don't only work in under-resourced, we don't only go to difficult places. That's just part of what we do. We found that, interestingly, there's uptake of our work in places like Sweden. So we really do try to, wherever we can build partnerships, build them, and then adapt our programs and our content to be relevant to that territory, if that makes sense.
Makes perfect sense. Yeah. Other questions for the team? I know that we're all thinking of everything you talked about. I have sort of just a very logistical kind of silly question, but who keeps the data? Is that you, Amanda, or like where of the folks that you've seen? And
So we have Tin Soldiers as a centralized database, and we have to abide by extremely the South African POPI, or the equivalent to HIPAA laws, are extremely robust. And so we have to follow all sorts of rules and regulations about consent to have people on a database, how we keep that database, where we keep that database, permissions to share, which obviously we can't share the database, but permissions to share information. We've actually just developed a manual that's 21 pages long with annexures that are much longer. So then also making sure we abide by the international laws. But fortunately, the South African laws are so robust and so strict that we pretty much, if we get those covered, we get the international ones covered as well.
And I can perhaps add, we don't really collect much medical information. So when I see someone as a patient, their notes, I sort of keep them as a physician. They don't get stored by Tin Soldiers, or and we don't collect any kind of research information really. It's diagnosis with consent and name, and that's all. So it's not really, we don't really plan to sort of publish things and so on. So we don't have to. So we're not really doing research. We're keeping a database of what we've done rather than the other way around.
Yeah, and sorry, the database I was referring to was the healthcare professionals database.
Oh, I see. Okay.
So patients, we know who our FOP patients are, also from making sure they're okay and looking after them. But yeah, that definitely doesn't get shared ever with anyone without very specific consent.
Got it. Kim, do you want to take yourself off mute and ask your question?
Yeah, I just wanted to say something because I have FOP. Hi, Amanda.
Hi, Kim.
I just wanted to say I really appreciate what you guys are doing for not only the FOP community, but also for all those other undiagnosed people, because getting a diagnosis is everything really, because at least you have answers. So I just wanted to say that. So thank you guys for all your hard work.
Thanks, Kim. We're having many emotional times of hearing how grateful people are to get a diagnosis, especially in remote areas. And one of the things we always share with them is, no matter where you are in the world and no matter what your situation is, and as devastating as maybe an FOP diagnosis can be, it's always great to be connected and to understand what to do and what not to do. right? When you have FOP. And in many cases, these people are not so easily connected by the internet. And so we have gotten them connected in other ways. And I also wanted to just mention along the lines of sharing information is, you know, we have at Tin Soldiers for a little while participated in trying to get the patients on the IFOPA registry. And we encourage all patients, they're all told about the IFOPA programs and the registry so that they start to enter that data if they can themselves. And it's a process, and we hope to bring that forward even more in the future.
I just want to add one other thing there as well that's perhaps not too apparent. In many cases, we will be told that there's a doctor, and normally it comes through Chris or someone within our clinicians network. But for example, the Prayers Congress, a doctor at the Prayers Conference from Libya, as a direct result of that training, diagnosed a child. So we know who the doctor is. We know there's a diagnosis. We tell that clinician, these are the resources. If there's a national organization that they can be a part of, like in India, we had a new diagnosis there. We connected doctor to patient organization, so that then the doctor can tell the patient and their family there are these resources. So in many cases, even though we know of a new diagnosis, in terms of obviously having to protect patient information, we might not know who that patient is, but we make sure that their physician understands how they can be connected to appropriate support other than medical.
And I can perhaps add there that sometimes is the biggest challenge is if someone's really in a faraway area and we don't have a good network of people either through our professional networks or the Tin Soldier networks or through IFOPA or the ICC or through the Musculoskeletal Global Task Force, then we do sometimes struggle to get doctors to care or to get a physician to pick up the phone and speak to us. And that's just a challenge that's ongoing, and I'm not sure we'll ever find the exact answer, but I think as our network grows, that will get easier.
Well, thank you again for the wonderful presentation. Do we have any more questions? We probably have time for one or two more.
Tracy, Laura, I hope I can be heard.
You can.
Just extraordinary set of presentations. Thank you so very much. You know, this issue of getting clinicians to be involved and interested in rare disease is always a challenging one. And particularly across the age span, we coming from the perspective of OI, you know, we have such a large number of adults who have trouble getting the care that they deserve. What are some of your, as you look forward to branching out, what do you think are your most successful strategies, and where do you see yourself going over the next 5 to 10 years?
I'll take part of that one, just because it's because I share that exact problem and concern, and in a way, being a pediatrician or being a pediatric rheumatologist has made that a little bit easier for me, because pediatric rheumatologists generally are interested in rare diseases and are generally amenable to trying to help people with rare diseases, and they're my crowd, so maybe I have some influence, but it's very difficult to get the once the patients are not children anymore. That is actually for me the biggest challenge, even within our own hospital and healthcare system, to try and transition patients into adult care, because patients with rare diseases often don't fit with any one particular person. You know, in our setting, osteogenesis imperfecta gets looked after very well by pediatric endocrinologists, and FOP by me. In some places, FOP is looked after by a dermatologist. And it's very hard to get another dermatologist to care about FOP, or sometimes to get another specialist who's very focused and very huge clinics in an adult setting to do that. So that is a tremendous challenge, actually, and I'm not sure I have the answers, but I think what we need to start doing is spread this, use the storytelling to inspire other physicians to see the value in what we do by showing them the value of caring for the individual patient, the patient in front of you. Because at medical school, often, I don't know if you had the same experience, the moniker was always, don't worry about the rest stuff, worry about the common stuff, and the rest, like pick the low-hanging fruit, and the other things must look after themselves. I think that's quite prevalent in a lot of medical education. So I think perhaps we'll have a newer generation of physicians growing up who are exposed to this kind of thing, who will have us, and with the advent of more sort of personalized molecular medicine, everything's almost becoming a rare disease because we can break it into so many, all diseases into so many different bits. So I think that it will change with time. But one of the things that we will do is I'm going to speak at the adult rheumatology conference this year on musculoskeletal, on this kind of topic, to try and get people interested. So I think it's about using the energy in the room and spreading the message to the most receptive people you can find. But yeah, it is a challenge. I don't know if Adette and Amanda and Vanda, they all three are the big strategists. I just see the patients. Yeah.
So just to add on that, in terms of strategy, it's all about creating stories and content that really put that patient voice front and center, to get clinicians that when we engage with them, that they really do care, that they're seeing the lives that need to be helped and are being helped. And so it's about taking that content, consolidating it, adapting it, and amplifying it as far and as wide as possible on the various platforms that we can engage with healthcare professionals globally. So that really is the central to our strategy. Vanda, I don't know if you'd like to add anything to that. And Kathleen, I saw you had your hand up. We'd love to take your question if there's time.
Okay.
No, go ahead, Kathleen, sorry.
Okay, not at all. I was just going to ask if the finding of these additional patients has furthered FOP in the ongoing research that's being done. Has that been helpful to the research effort? And also, how significant was it that you found what I understand was the first multi-generational family with FOP? Was that medically very significant?
I can sort of address those very first of all, this is the first multi-generational family in South Africa, but you're right, that is a very significant finding, and that was Amanda was involved with the first multi-generational families globally. I think that was identified in Brazil, and Amanda, through Professor Fred Kaplan, through working with him, I think that led directly to the identification of the gene, which of course revolutionized everything for us. But in terms of what it's done for our research, I think what we're trying to do once we find patients is connect them, first of all, to the very important work that the IFAPA is doing, especially the patient registry, the natural history studies, and so on. And that so there's a contribution there, but I think it's a slow-moving part in that we'll probably only see effects later. The second thing is that clinical trials in FOP are busy rolling out now, and the first sort of wave of clinical trials have happened, and I think going forward in the future, in order to investigate newer therapies, it's going to be important to have identified patients, so that clinical trials can also move outside of Europe and the US and Canada, and into areas where there are more patients who can then hopefully benefit from those clinical trials as well, and who deserve to have drugs tested on them because of their different genetic and environmental backgrounds anyway. So, but I think that will be the longer term contribution. But I think that's also will take time to come to fruition.
Thank you.
Well, again, to the team, thank you so much. What a wonderful presentation. And I know, I think we have your contact information. Amanda, I don't know if we want to, are your email addresses all in the,
I'll put our email addresses up, and also I'll also just put links to some of our content in the chat. We had another very short piece, but I think it's better if you watch it in a platform where the quality is better. So I'll just put those links up and our email addresses. Chris, you're happy for me to post your email address, right? I'm sure he is. Okay.
Great, thank you.
Tracy,
go ahead.
if I could just have one more moment.
Sure.
I do think that something that we didn't touch on is that we have found an incredible reception educating healthcare providers such as nurses. And the educational program that Tin Soldiers had was rolled out in Sweden as well to many in the nurses' education. And so diagnosis can happen not only with a physician, obviously, but with nurses, and even in underdeveloped countries, the informal healthcare provider can also help the diagnosis, as long as you have a chain of expertise to connect with. And so it's not always physicians, and especially when those nurses have someone to contact immediately. And one of our first nurses in a remote area contacted Odette, I believe, on Christmas Day. So, that's the kind of response that needs to happen. And the other thing is, I would love for anyone who's interested in learning more about the work, or has any kind of questions on what might work for your organization. We're more than happy. We're very transparent, and would love to be able to share with any of the Alliance members any of that information.
Wonderful.
Thank you for the opportunity.
Absolutely. Thank you, Amanda. Thank you, everyone. So the last thing on our agenda is we did listening sessions throughout the last few months, and Michael Stewart, our Director of Education, is going to give you a little bit of information on what people were telling us in the listening session. So Michael, I'll turn it over to you.
Thank you, Tracy. So can everyone see and hear these slides well? Perfect, thank you. So as Tracy mentioned, I am the Director of Education at the OI Foundation, and one way in which I was involved in this current PCOR award is I was moderating and helped managing the listening session portion of this program. And I'm going to go over to some details of how it was structured, and then talk about some of the major findings from those listening sessions. So real quick, excuse me. So the overall process, so we conducted 4 listening sessions overall, 2 with patient groups, 1 with stakeholders, or in this case, meaning other professionals working in patient advocacy organizations, and then 1 with clinicians or care providers. After doing or moderating all of those listening sessions and receiving that information, we did a thematic analysis of those recordings. Basically, what we're trying to do is determine what are the big takeaways from all of those groups and all those individuals. And any information we're presenting and any quotes are de-identified, both here and in a final report that we're going to do later. So I'm going to talk about the 4 big domains that we were looking to get more information on. or sorry, not four, the three big domains that we're trying to get information on. So the first one is about what were the patient-identified issues that need to be reflected in the development of patient-reported outcomes. And we'll go more into depth into each of these in a little bit. The second one was what were the barriers and facilitators to accessing care? And also within that, what does excellent care even look like? And then finally, what were the barriers and facilitators to participating in research projects? So I'm going to talk about each one of these domains separately. So I'm going to talk about that D1 first. So in patient-identified issues and patient-reported outcomes, this one was very fascinating. We heard a lot of different, very fascinating subjective answers. Among some of our large trends that we found was all groups talked about a need for open, honest communication with patients, between patients and care providers. This would be reflected in different ways to different groups, but basically people felt that either they were not speaking enough with care providers or that they were not talking about the things that they really wanted to talk about with care providers. And also the care providers themselves acknowledged this potential disconnect as well when they were talking about patient-identified issues. Another was, and this was pretty universal, almost every single individual we talked to brought this up, was the importance of pain, both the subjective experience of pain and talking about treatments for pain, to be more centered in communication with patients and also care and treatment of patients. Furthermore, they talked about a lack of adult care options. So many community members that we talked to brought up the fact that for many of these conditions, there are relatively more pediatric medical providers, more treatment options, more research being done in the pediatric space than there are in adult space. But one sort of reality of, as the science progresses, as treatments become more and more effective, as patients' outcomes increase, these children become adults. But then the medical support for those adults is not there. So that scaffolding needs to increase with the age of the patient population as well. And something I found very fascinating was that we asked some questions about how do people define quality of life for patients with rare bone diseases. And one thing we found kind of interesting was that, so all our patients gave us very fascinating personal definitions of what quality of life to them meant. And also we got very few definitions from either the stakeholder group or from clinicians, with many of them saying that is a subjective thing that they could not answer, which I think is interesting and of note. So on the next slide, I'm just going to go over some of those specific definitions they gave. And I'm just going to read them out loud. The first I thought was interesting was quality of life. And so these are direct quotes that we heard during some of these listening sessions, all from patients, was quality of life would mean pretty much it's a measurement of daily living and tasks and things that I'm able to do in life. Also from someone else, I would see quality of life as a pain measurement system, and that was very specific. Another one was saying, for myself, being able to do things that I wasn't able to do, maybe a modified way, but also hopefully without pain. And I've realized that as I've gotten older and there's more bone pain, so the quality of life for me would be to keep plugging through, but hopefully I won't hurt as much today as I did yesterday. I think all of these are sort of fascinating and bring up this larger sense of, some of those larger trends I brought up before, that all groups brought up that pain needs to be talked about more and thought about more critically. Also that they just want to have some basic sense of being able to get through daily tasks. I want to talk about now the second big theme or the second big domain of questions that we asked, which is about access to care. So, and also within this, we're going to talk about barriers and facilitators that allow people to access care. So the first big takeaway I want to talk about is a common definition that kept coming up again and again, which was that coordinated multidisciplinary care was seen as an ideal care model. So when I say multidisciplinary, I mean having multiple medical professionals being able to treat you as a holistic person. And then when I say coordinated, what I mean is that there is one major decision maker within that medical team helping coordinate or make those decisions for you. I thought it was also noteworthy that even within this, like, you know, when we're there defining what the ideal model of care is, many patients brought up this concept that they felt a burden of having to coordinate their own care and how tiring and stressful that experience was. So that even in the best case scenario of receiving coordinated multidisciplinary care, they still felt stressors within that system. Furthermore, I want to talk about facilitators, so things that made it easier for them to get better care. One, I thought this was interesting, was a willingness of care providers to learn and ask questions. I bring that up because multiple individuals talked about how when they are seeking when they're looking for a new care provider to give them a diagnosis or a treatment about a specific issue, many of them talked about how the true medical experts in the field are few and far in between. They may be at major research institutions, what some organizations would call centers for excellence, and those are few and far in between. And so the reality is they have to find doctors that they can work with in a more local setting if they don't live by those major centers. And it was interesting that they brought up that to them, more so than expertise, they were happier when they worked with doctors who asked them straightforward and also thoughtful questions about their conditions and their care, acknowledging that those patients themselves may be the expert on the condition within that exam room. Also, many of them talked about how telemedicine is an option that may not have been available to them a few even years ago, but to very few people, it felt like an ideal tool for getting their medical care. Almost universally, the people we talked to in these listening sessions who were patients with rare diseases would prefer to see a doctor in person, one-on-one. Also, I want to talk about barriers to accessing better care. So one is just travel, and this is related to people acknowledging that these specialists are few and far in between, so that when they did feel they had to see them, traveling is difficult, whether it be the financial burden of traveling or there is specific medical stressors around these patients traveling, whether it be fear of injury during traveling or something else. Beyond that, someone talked about, not someone, but many people talked about the financial burden also with seeking care. And so people we interviewed, just for context, were all American, so they were all talking from a US healthcare perspective. But one quote I thought that summed it up quite well was someone said, "Rare disease doesn't know geography, but unfortunately insurance does." And I thought that really summed up what many people were saying, was that the rare bone disease population is spread out everywhere. However, the insurance location to location is vastly different, to the point where even the medical professionals often don't know all the intricacies of their local area or situation. Another thing people talked about was the potential trauma around the medical diagnosis. So we asked everyone about what was their medical diagnosis odyssey like? So it was one of our major questions. And multiple people talked about how, and also the care providers themselves talked about how there is trauma for various reasons around getting a diagnosis, whether it be doctors in the past have misdiagnosed a person, therefore they received maybe surgeries incorrectly when they shouldn't have, or maybe there was accusations of non-accidental trauma and family services had to separate parents from children. And this creates legitimate trauma for the patients and the rare disease community. And if you've experienced trauma, you may be disencouraged to seek further medical care if you feel like you've been mishandled in the past, or if you feel like your family has been mishandled in the past. And furthermore, just a final thing similar to the other thing is that people said also reason why they're not getting care is that they don't know where particularly the adult care options are, similar to what we talked about before. And here I have some quotes previous to the similar section around what some individuals were saying. So I know more about my disease than some of my doctors I see, but that's okay. That's how it is. But if they're willing to learn, that's super helpful. I thought this summed up a lot of the major points that I was seeing throughout these listening sessions around getting care. This one I thought was very interesting as well. It'd be nice to not have to constantly be an advocate for yourself. Yes, it's important, but it would also be nice for them to say, hey, we know how to handle this. And this is in context of when you go into a doctor's office and they say, hey, we know how to handle this. And this is from a larger quote here. And again, it's like that holistic look at it, all the team members that are necessary, because yes, the surgeon will just want to do surgery. I was suggested surgery so many times in my adult life. And so I just realized at some point, I was like, yeah, wait, I'm seeing a surgeon. They're going to tell me they need to do surgery on me. I thought this was a very fascinating point this person brought up, the idea that, not that surgeons are thinking about necessarily one thing, but if you are seeing one specialty, they're going to view it through the lens of how their specialty handles a thing. And that may not necessarily be the least intrusive or best course of action. Again, highlighting that need for multidisciplinary care. And this is from actually a medical provider talking about getting a diagnosis can be so traumatic that it can establish a resentment towards the medical system. And we, meaning the medical professionals, have to rebuild that in our care. So I'm going to go now to the third domain. So what were the barriers and facilitators to participating in research? And I just have a few more slides left. So some of the facilitators. Specifically, some of the attendees were talking about one theme I was really seeing was that the more connection a person had to a patient advocacy organization, that translated pretty directly to more knowledge about research. So what I mean by that is a leader of a patient advocacy organization knew more about research opportunities than one of their board members did. And one of their board members knew more about research opportunities than a volunteer of that organization did. And I don't view this necessarily as a failing of anyone. I actually view it as the fact that the patient advocacy organizations are well tapped into research opportunities. And it's just a matter of the more you know, the more connected you are to your research, your patient advocacy organization, the more you know about ways you can participate. Also, every participant talked about how they saw altruistic and personal benefits to participating in research. So both, when we ask questions about why do you think it's important to participate in research as a person with a rare bone disease, all of them talked about how, there is a need to drive science forward. And if we don't do this, who else will? And I view that as very encouraging, that we don't need to sell people necessarily on the altruistic benefits or importance of participating in research. But also people said, on the flip side, if I am participating in a study, it is tapping me into more medical resources. Or if this is a drug treatment, for example, a drug treatment trial, I am potentially getting a new medication before the larger population. And I thought that was worth noting. Some barriers, again, travel and transportation. And also, some people brought up the inclusion and exclusion criteria for studies. And so meaning, are certain studies too specific on who they're including versus could they widen their net of people they're accepting? And finally, there seemed to be more interest in drug trials and other types of studies, specifically around natural histories, where they're just doing measurements of you over long periods of time without like a treatment option being offered. And so with that being said, those are some of our big takeaways. Finally, I just want to have some very small reflections. These are some things where I was noting with the listening session team, is that so overall, and then this is my take it with a grain of salt slide. So we had a relatively small sample size of participants. We had 4 listening sessions in total, and with the largest one being 3 attendees and the smallest one being 2. So these were all quite small. Also, I want to bring up the fact that the rare bone disease space is a relatively small community with no real anonymity. So what that means is, even though we can try to say, these quotes will be de-identified and your information will be, your name won't be attached to it, there's still the worry that people aren't saying what they really think because sometimes we know each other. And then obviously, finally, time constraints, which also I want to be aware of for this session as well. But before I wrap this up, I want to thank quickly some other people on my team, specifically Stacy Loring, who is the grant manager and the special projects manager at the OI Foundation, as well as Terry at Duke, who was sort of the mastermind for helping us structure these listening sessions. So with that being said, I sort of breezed through lots of information. We have about 4 minutes to answer questions, and I'd be happy to answer any questions from the group. Thank you all.
Thank you, Michael, very much. For those of you who know Michael, know he is an excellent facilitator. So I wasn't allowed to sit in on the listening sessions, but I heard he did a fabulous job. So thank you, Michael. Any questions? And we'll continue to have more information on this because we will do a final report, correct, Michael? And we'll have more information.
Yeah, so we'll be writing up a larger report of these findings in the next couple of weeks. So what I presented on today was just like, these are the big, very obvious takeaways that got brought up in at least 3 out of 4 of our listening sessions.
Great. Well, we are at the end of our time. Michael, unless there's something else you wanted to mention there? But I wanted to thank all of my Rare Bone Disease Alliance colleagues for this really wonderful experience for me personally and as the leader of the OI Foundation. Dr. Tosi, I don't know if you want to jump in and say goodbye and thank you to everyone before we leave, or?
Absolutely. This has been great fun, and it such a wonderful opportunity to share. When we wrote the grant, we had great hopes that we would help bring the Rare Bone Disease Alliance community together more, and that we would share a ton. And we've gone so far beyond our original hopes and dreams. And I thank everyone on this call for participating and helping make that a reality. As we look to grow the Rare Bone Disease Alliance, you will be our resource too in terms of helping organizations and individuals get more help and work together as a community. I think we've heard team today, and I think that's how you help the greatest number of folks. So thanks everyone for being a part of this, and we look forward to our next steps.
Thanks so much, everyone. Have a great night, day, morning, wherever you are in the world. Thank you.
Thank you.
Thank you, everyone.